Thanks so much, Mr. Chairman. Thank you, Ali. Very nice talk. And today I'm going to show you what we learned and what we do routinely and how we put what we do routinely on steroids, thanks for the introduction of AI. Continuous failure of intravenous TPA is a major concern, and we don't know what's going on. And TPA utilization has increased by tenfold, but only less than 4% of all stroke patients benefit from such a shot-in-the-dark scenario. There's an urgent need to develop new technique that provides global brain protection for neuronal and non-neuronal injured cells. To overcome practical challenges, we introduced triple neuroprotection in patients undergoing emergency carotid endarterectomy after failed TPA and or beyond 24 hours of therapeutic window.
That the government regulators have been bought off by big pharma. I think that's what you're saying when you say that this entanglement has occurred. You said agency employees are actually getting royalties, getting payments on vaccines and drugs that they approve. Is that true?
Yes, there's a couple of things happening. With FDA, about 50% of FDA's budget comes from regulated industries, so mainly the pharmaceutical industries. You have agency capture on steroids. The principal objective of FDA today is to serve the mercantile interests of pharmaceutical companies. And that's why you see FDA not only approving all of these drugs that shouldn't be approved, but they also are, out to destroy things that are actually shown to be good for you that do not make profits for the pharmaceutical companies. But then,
so I'll show you why. So we start using general AI in this particular part about the TPA, and we discover crazy stuff. So this is the trials in 1998 to 2000. A failed trial with 2.5-fold of in-cerebral bleed in 94% of the patient. However, they approved for $200 per IV shot for physician neurologists. So if you give that order and sign for it, your bank will increase by $2,000. And then move to a CAS 3. At play, TPA was more frequently associated with symptomatic intracranial hemorrhage, and I show you the finding over there versus placebo. And this is 2012. And what happened? They approved increase from $2,000 to $2,500 per IV shot for physician neurologist. Then came back in 2013 to 2021, and you could see in here exactly the increased risk of in-cerebral hemorrhage. And what they have done, they approved for $3,000 per intravenous shot for physician neurologist. This is under the FDA nose, by the way. TPA is the Russian roulette. Any alternative to TPA failure has been donatic, challenging wake-up ischemic stroke patient managed while passively waiting to observe a clinical response to intravenous thrombolysis. Uncertainty exists in the strategy of those presenting beyond the therapeutic TPA window. Clinical dilemma in this situation, prolonged transitional period of inertia, resulting in major adverse neurological outcome. There is insufficient evidence for treatment recommendation in this patient, and they are particularly vulnerable to disabilities and deaths. Triple neuroprotection in this subgroup serves a dual advantage purpose: overcome therapeutic uncertainty and increase favorable outcome. And as you can see, it's very simple. Anybody could do. You don't need to get machines to do it. You just put a couple of cold packs over the groin, axilla, and behind the vertebral artery, and you give a cold saline, and you decrease the temperature in the room to about 19 degrees. Is what you currently do, but on steroids. So literature evidence of triple neuroprotection, there is the hypothermia, the foundation, and everybody knows about it. There is the induced hypertension, which you do it. We never shunt, so we usually increase the blood pressure during our surgery, so you do that. And barbiturate brain suppression, we know that from kids who came in with status epilepticus, the minute you give them the barbiturate, the cerebral metabolic rate of the oxygen of the brain drops by 80%, so you're preserving the brain. So you usually do that. And what we have done, we put that on steroids in order to improve the outcome of our patients. Then we looked at the super AI, where machine superpassing its cognitive capacity, to see how we could improve that more. So the first thing said, why you wait for a randomized controlled trial? It's unattainable in the AI area. We currently cool the theater, raise blood pressure, and sedate the patient during routine carotid surgery. Triple neuroprotection simply put this on a steroid for acute stroke patient. Only 4% of stroke patients benefit from TPA. There is a pressing requirement for neuroprotection technique. The cardiothoracic parallel, already standard practice when you're going to do a 4-vessel debranching, open, you cool the patient. So I'm not getting something out of my mind. It's already proven in a lot of trials. So this is the patient, comes in, as you're doing a normal carotid, you give the local, you put the packs around his head and neck, and then you start doing the surgery. You have to drop the temperature of the patient to about 31 to 32 degrees, and you wait until the EEG of the brain goes 0. How do you know that? You pick the ECG of the patient on the brain versus getting an EEG of the brain. So the EEG that's been put on the forehead of the patient, because the brain's totally suppressed, pick up the ECG signals on the floor of the brain. And it's becoming a routine for us to do it, and because nobody wants to take this responsibility, everybody have somebody who have passed the 24-hour window, just put him in an ambulance, said it to this guy who's doing this crazy surgery. And believe it or not, the patient wake up perfectly well. The whole idea that you have to get the blood pressure to 190 systolic, you have to drop the temperature to 30 degrees, and you have to abolish the activity of the brain. You have to increase the barbiturate infusion until the brain, it's like the adenosine you give to the heart, we give the barbiturate to the brain to stop the brain activity. And it's reproducible, and this is a patient came in with total occlusion, as you could see over there, post COVID infection, and they had a coronary angiogram, and during the coronary angiogram he got stroke, and then he was thrombolized, it didn't work, and definitely give it to Sherif to do. And it's reproducible. You could do a patch or you could do an eversion, and then we do a completion angiogram at the end in case that there is any clot have been left inside at M1, M2. And I'll show you the trick how we're going to treat with this. And it's very simple, pediatric suction for interhumeral thrombus aspiration. I don't use any of this major stuff that's available to retreat it. We just get the baby pediatric suction, put it in. It acts like a penumbra, and just put it in and get the anesthesia to increase the blood pressure and suck gently, and you're going to get all the clot. And you can see it in here. This is actively, you see the clot have been sucked totally out without anything, without doing anything, and then you could see the bleeding coming in nicely out of the internal carotid artery, and the patient have a patch and everything goes hunky-dory. Now, COVID has created havoc on our patient. This is a patient had a previous stenting and thrombose and came in totally not moving anything. She was talking, that's the only thing. And we went on and we have opened the neck because she had a contralateral occlusion, and we done a bypass after excision in it. COVID have created a lot of havoc. Over 12,000 patients referred with carotid artery disease. 832 had carotid intervention between 2002 and 2019. This is prior to what we collected. Patient had either failed TPA or had past recommended time for acute stroke. And as you can see in here, this is the ABCD I score, and you can see all of them, 92% have unilateral weakness, and a lot of them had ipsilateral problems. And this is the carotid duplex, and 84% had 99%, and 16% have a contralateral occlusion. 24% had evergent endarterectomy, 72 had endarterectomy with patch, and 4% had a primary closure. And this is the ranking score. You see, they went on from ranking score 2 to 5 to ranking score 3 to 0. 80% went back to near normal after the towel had been thrown by the neurologist/stroke physician. There were no cases of MI, stroke, or death, no cases of cranial nerve injury, wound, hematoma, or procedural bleeding. Mean follow-up period is 9 months, and all cases of total neglect had resolution of neurological symptoms. 3 patients had recurrent stenosis of less than 50% at 16 months, but remained totally asymptomatic. 88% of the patient went home. Remember that. 12 require rehabilitation. And I'm going to show you a few cases. So this is a nurse, was working, and then she got stroke, and she can't move, as you can see in here. And I'll show you the video after we have done the surgery for her. Now, after the surgery, we keep them intubated. We wake them up, but keep them intubated until the temperature goes about 37. Because if you wake them up while they're cold, they shiver, and it's crazy. And you can see yourself, all of them have the tube in their mouth, and they are typing, texting to the loved one. And then after that, we extubate them, and everything goes well for them. And this is the same nurse that you see over there. This is 2 days after the surgery. She's walking out from the stroke unit happy. after she was bedridden and the towel was being thrown by the stroke physician, and it's reproducible. This is the last slide. The era of inertia is over, and the AI-powered future. AI predicts who will recover, cost effectiveness of the targeted intervention, proactive patient selection over passive hope, take control, predict outcomes, save lives. Cost effectiveness of success supersedes cost of inertia. AI-driven prediction combined with triple neuroprotection will transform acute stroke care from passive hope to precision medicine. Empower your patient. Don't leave them in limbo, and take control of such patient who nobody care about them and been thrown out into the stroke ward for rehabilitation that never happened. Thank you so much for the opportunity.
Thank you, Sherif.